Perfect. Thank you. So again, I'm Darlene Torres Vaz, and I am here presenting as part of Harmony Health, and I will introduce my colleague. Go ahead and share who you are.
Hi, good afternoon, everyone. I'm Esmeralda Aguilera, LCSW, and I am happy to be here and happy holidays to everyone.
And thank you for those who have started to put their name, agency, and one of the things that they are struggling with. Today, again, you see that we're going to be kind of having some education on skill-based and trauma-informed documentation with our progress notes. The work that we're going to be presenting clearly tells the client's story, demonstrates medical necessity, and protects both the client and our role as case managers. It's very important for us to make sure that we have strong documentation, not only because it's a billing requirement, because it shows impact, continuity of care, and accountability. So, just kind of some ways to preface what this training will look like. Next slide, please. All right. So by the end of this training, you should feel confident about identifying all required components of a strong progress note using trauma-informed and non-stigmatizing language. We'll be documenting real skill-based interventions and not just tasks, and clearly linking your notes back to the care plan goals using, again, the golden thread that we've been speaking about throughout our various trainings. We will cover how documentation supports proper care plan updates and appropriate disenrollment and discharge. Pretty key components there. Next slide, please. All right. So in prior sessions, we've built that foundation. We've talked about assessments. We've talked about care planning, SDOH needs, Z codes, SMART goals, and interventions. Today, our focus is where everything comes together. How all of that planning turns into real-time documentation through progress notes, care plans, and transition summaries. This is where your work becomes visible, defensible, and also very prepared for audits. Next slide, please. And I'm handing it over to Esmeralda.
All right, thanks. All right, so here I want to ground ourselves into the why we document. Progress notes are more than a compliance task. They tell the story of the evolving story of a client across time. Anyone reading the chart, whether today or months later, from now, they should be able to understand the client's story, what is happening with them, what services they were receiving, and why certain decisions were being made throughout this process. Um, Progress notes should also include meaningful updates, not just the activities. You've heard me mention this in previous sessions that we've had. We want to capture the changes in the needs, the barriers, the functioning risk, any social determinants of health that help understand how the client is doing and what they need next. This is especially important in ECM where we're tying the medical necessity to demonstrating the complexity and the cares for the care coordinations that are being provided. We also want to highlight your role as case managers. We really want to emphasize that the role that you're doing and the work that you're doing is really skill based. And we want to make sure we're documenting. You're coaching, you're advocating, you're coordinating with partner agencies, you're problem solving, or you're doing health navigation. This is key in differentiating the ECM from just providing a resource list. And it's also reinforcing the work that you're doing. We want to make sure we're justifying everything. And you're also giving yourself the credit for all the work that you're doing. So I really want to make sure that if there's something that you're getting from these trainings is that you are highlighting the skill-based interventions that you're doing with all your clients. Um, and again, we're tying all this back. We're documenting progress towards the goals. You've identified the goals, you created a care plan. Now let's start showing what you're doing. You know, explaining why the progress is why there's limitations is essential in how you tell the story or what progress the clients are making. If a client is not making any progress due to a systematic barrier, housing, for example, there is no housing, that you have that limitation, you want to document that. Is there any stigma happening? Is it transportation? Is there lack of trust within the system? We sometimes see that in the system where some of your clients don't want to go to a resource or referral that you've given them. Um, we want to make sure we're documenting what is the barrier that is happening and how is it that you're supporting them. Another key purpose is the communication. So here we also want to make sure that we are documenting any kind of partnerships that we are having with our clients to ensure that we're meeting their care plan needs. Are we talking to medical providers, therapists, county teams, any community agencies? Um, Often they rely on the charts to understand what work has been happening. Clear notes help prevent any duplication. So again, you're also reading other people's notes. So you want to also ensure that you're not duplicating the work. You're supporting, and this really helps also as you start working with other organizations, that you have an open communication and collaboration of who's doing what. Finally, our progress note supports our audit readiness. In ECM, this is highly regulated within the program. There are expectations, there's medical necessity that comes along, and the ongoing need for case management and the responsibilities for the clients. I also want to touch base on the fact that, we note that progress that should not be very vague. We want to make sure that we are documenting clear, like I mentioned, interventions. So we're not just saying, I checked in with my client today, or client is doing well. Okay, we need more context for that. We gave resources. Again, that's providing tasks that you're completing. We want to make sure that documentation is really clear. These kind of statements don't really tell a clinical story and don't reflect the depth of the case management work. We want to move beyond activity-based documentation to intentional, meaningful documentation that supports outcomes and compliance. Next slide, please. All right, so here, these are what we want to touch on in regards to elements of what a strong progress note would be. So a reason for contact. We always want to begin with the why the encounter is happening. Why are you meeting with your client? What specific goals, barriers, needs, or any issues that you will be addressing or discussing that day. This really sets the frame for the entire note and keeps our communication intentional rather than activity-based. So you're setting up the stage for what that visit was for. Your client status and updates. These include meaningful updates on how your client is doing. So this may include any new barriers, any new challenges in functioning, updates on medical behavioral health needs, any shifts in motivation or readiness. Is the patient or the client willing to do the tasks that are being, like, where is their motivation? What is their buy-in in that visit in particular? The client voiced or their perspective. And then any SDOH, any social determinants of health, updates that are affecting their care. These updates really help to demonstrate ongoing medical necessity and ensure that the story remains current. Next thing we want to make sure our notes have are our case manager interventions. This is where you will be documenting in the section of your note your skill-based interventions, not just generic actions that you would be doing. So examples, you're coordinating care or navigating systems, you're completing a warm handoff, you're advocating on behalf of your client in a specific system that you're working with, benefits and resource navigation. It's not just giving them that list of phone numbers, but you're also kind of helping them close that loop, making sure they know how to contact that person. I will say one of the skill-based interventions that are really important is when you're closing the loop on the referrals is really meeting them where they're at. Sometimes we make the mistake of handing a phone number, giving a phone number to someone and expect them to just call that number. Sometimes you want to ask the question, is that individual, how are they going to call? Do they know what to say when they get a prompt? Do they know to press 1? Do they know how to ask for the questions and the resources? A lot of times I will recommend for anybody doing any kind of benefits, crisis navigation, resource, or any information that you kind of almost role play with your client to make sure that they know the steps needed for them to close the loop on whatever referral that you're supporting them with. Um, and that also comes into the coaching part of it, the problem solving. Are you supporting them in those regards? This is where we really differentiate the ECM case management from simply giving that information. It reflects your professional skill sets that you're all providing within your clients, for your clients. Next, we want to document the client response. This is such as important of documenting is after you do your interventions, how do they respond? Do they understand? Do they agree? Do they express any concerns? Did they show any readiness to acting on whatever the intervention was with them? You're capturing your client's response is very critical because it shows the direction and the nature of case management and their understanding, as well as guiding the progress towards the goals. If you need to pivot, if you need to change, this is crucial part in your documentation to prove that. Next steps. This is the other part that is crucial in your notes. In case management is we plan what the next steps are going to be, what's happening. Your plan as a case manager, your client's plan, what do they agree that the next action items are going to be, and then the time frames for the follow-ups. You want to document when these tasks are going to be completing. You know, you gave your client information to apply for CalFresh, you gave them helped them make the call, they have that initial appointment, and you know the appointment time. You are documenting the time when they have that appointment. Are you going with them, or is the client going by themselves? Do they know how to set up their transportation? So this is the part where you really will be kind of documenting those next steps. And then finally, as your way to just ensuring you have everything there and you're documenting everything accordingly that will meet the medical necessity, you're linking them all to the golden thread kind of concept that we've been presenting to everyone. Here you're asking yourself, which goals does this intervention support? How does today's contact move the client closer to reaching those goals? So you're documenting those goals that you've established with them. This ensures that the interventions, goals, assessments are all linked together. So they're almost like your checkbox. And it's one of the most important elements that auditors will be looking at. They want to see everything being tied in together. So key things I do want to reinforce here is if any of these elements are missing, your note is technically incomplete. This is a standard for a strong, defensible, and client-centered documentation because you are capturing everything that you did on that one day with your client. Next slide. All right. So here we're going to focus on the first elements of a strong progress note, the reason for contact. So I'm going to go in here a little bit more in detail. So strong examples here on a strong note is for contact that ties directly to the care plan or a specific barrier. So for example, follow up on a care plan goal related to housing stability. This links to a specific goal and it shows intentionality. Address new transportation barriers that cause missed appointment. This is timely, specific, and reflective of real client needs. Support client with completing benefits applications. This shows a defined task that requires a case management intervention. Progress on behavioral health linkage and follow-up plan. This demonstrates coordination with other systems and providers. So these examples make it clear what the focus of that encounter will be, and it also provides the roadmap for the rest of the note. I will say every agency has their ways of how they like to document and in what sections. You also want to be including where you saw them. Was it in person? Was it telehealth visit? Was it over the phone? What kind of modality was utilized during the visit or the encounter? You do document those on the notes. I'm not touching too much on that because every organization has that differently, but I will really suggest that everyone really touch base with their organization specific. Where is it that they would like to have that documented? So things to avoid. These are examples we often see that would be an incomplete documentation. Again, you just document follow-up. no context to it. Routine check-in, again, there's no context. Routine check-in for what? You see what the client to see what the client needs today. Again, what is it? What goals? What is it? Like you need to have a little bit more information for that to be a completed note. While these may describe general intent of the visit, they do not show the medical necessity. They do not connect the care plan, and they don't provide enough details for someone reading the chart later, or even for an auditor when they're reviewing the case. Okay, so her reason for strong contact is very specific, goal aligned, and an actionable encounter. Next slide. Okay, so here, we're documenting, I'm going to touch a little bit on the documenting the client status. How do you document the client's current status? Is a way that is accurate, respectful, and aligns with the trauma-informed care. This section of the note helps us understand what has changed for the client since the last contact, whether that's improved, is there any new barriers, or a shift in functioning. We really want to be mindful here that we're using neutral trauma-informed language. We want our documentation to avoid labels or judgments. Instead, we want to describe the situation or the behavior that's happening. So let's talk through a little bit of these examples. Experiencing housing instability instead of homeless. This is centered on the situation, not the identity, and it is more respectful and still clinically accurate. Client reports barriers attending appointments instead of non-compliant. Some of you that might have been doing some chart reviews might see this sometimes come about. Medical providers sometimes, unfortunately, will use client that has been non-compliant as a term to describe when a client has not been able to follow through with treatment plans. Non-compliant implies blame. Barriers point us towards problem solving and support. So a client reports barriers attending appointments. Client express uncertainty instead of uncooperative. Again, we point out the client's lived experience, not a negative label. Client shares feeling overwhelmed instead of client is difficult. Documenting the client's emotions increases empathy and creates more accurate picture of what they're navigating. So this type of language promotes dignity and reduces stigma, both which are essential when writing documentation that clients have legal rights to review. Remember, these documentations are your clients, they belong to them, and they can request them at any point. So when you're writing these documentations, when you're making statements, we want to really ensure that it is something that they will read, and you know that you can explain to them and they're on board with the documentation that's being provided to them. All right, what we want to include in them. So when we're documenting client status, you want to capture a few key points. Changes in their SDOH, for example, housing barriers, food access, transportation, income changes, emotional well-being. How is the client coping? Any signs of stress, depression, anxiety, or improvements in their stability? Any safety concerns? If there are risks present, including behavioral health or environmental concerns, they must be noted factually and without any judgment. Sometimes it is appropriate and it is also useful to have in your notes, in your client's voice, when possible, short, direct quotes or paragraph statement capturing the client's perspective on things. This strengthens the golden thread and humanizes the notes for them. Okay, you want to next slide? I think I've spoken pretty in the previous slides also around our skills-based interventions. And I really want to continue to emphasize this part. Your interventions as case managers. What you document here should reflect your professional skills as case managers, not just the tasks completed. This is a key area auditors will be reviewing when determining whether ECM level case management really is medically necessary. So let's go through a little bit of these examples. Coordinated care between providers. This could be communication with the clinic, a specialist, a therapist, a county provider, a school, a community agency. Let's remember coordination of care, doing the actual work and the interventions is a key service for ECM. So we want to make sure we are capturing that and documenting that. Completed a warm handoff to housing or benefits agency. The warm handoff demonstrates an active support that you're doing. You're just not giving the information. Supported a client in completing an application. This shows the hands-on guidance, coaching, especially when you're navigating a complex system. Assisted with appointments, scheduling, or transportation. How you're reducing the access barriers by helping the client navigate the logistics. Reviewing care plan progress, problem solving any kind of barriers. This connects back to the golden thread and you're linking your interventions to the goals. You advocated for expediting services when needed. Your advocacy is a skilled intervention that demonstrates why ECM is necessary. So you have a client that might be needing county behavioral health services. They have not been able to get connected to county behavioral health services. You helping advocate, going with them to that walk-in intake visit, you going with them to ensure that they're a specific acuity or they're able to express themselves of what the needs are to the county is part of your advocacy services that you are providing. Provided education using accessible language. This is crucial. Teaching our clients how to use the benefits, navigating the systems, and understand recommendations is extremely valuable, especially when you're helping them interpret. Let's see. Supported crisis, de-escalating, and safety planning. This is a high-level intervention and must clearly be documented clearly when this occurs. These examples highlight an active, skill-based nature of the case manager, interventions that require training, judgment, and professional expertise. Each organization usually will have something in place to really help support when you are having a crisis with an individual. If they are having any risk factors that you need to escalate to a supervisor, behavioral health, and medical emergencies. This is crucial part of if you identify during one of your encounters that you do your diligence to ensure the safety of that client, as well as documenting what steps you took to ensure that safety for them. This protects you and protects the agency and it protects your clients as well. Let's see, so kind of going real briefly back to the not skill-based, left a voicemail, gave a client a phone number, told the client to follow up. These are tasks, they're not interventions, and they don't show a lot of value, they don't demonstrate the medical necessity, and they don't reflect the complexity of the ECM work that you are doing with your clients. If these are only actions that you are documenting without supporting the interventions of why you're doing these actions, it becomes very difficult as you move on with your encounters to show the medical necessity and to show the work that you're doing to support your clients. So when you're writing your interventions, I want you all to just kind of ask yourselves, did this action require my skill, judgment, knowledge of the system, problem solving, or advocacy? If yes, document it very clearly. If not, it likely doesn't belong as a primary intervention. This clarity protects both you and your client, the agency, and really helps to complete the story in a meaningful way to support your clients. Next slide. All right, section with documenting your client's responses. All right, let's walk through a few of these examples. The client expressed understanding of next steps. This shows comprehension and aligns with the plan. The client stated feeling less stressed after developing a plan. This ties the intervention directly to an improvement in their well-being. The client remains motivated and engaged in care, helping us monitor engagement over time. Client expressed ongoing barriers and requested additional supports. This gives your client insight into new and continuing needs, which guides further interventions. Client agreed to the plan and scheduled a follow-up. This shows readiness for action in collaboration with the care planning. So these examples demonstrate that documenting your client's responses is more than a courtesy. It paints a clear picture of whether the interventions were effective and what your client needs next. This shows your client's participation. Their documentation reflects a two-way conversation, not a unilateral action by the case manager. It's not you just telling them. This has your client's voice. It includes your client's perspective on their strengths, trauma-informed, and is person-centered. Engagement level. This is also helping you track engagement over time, helps identify when additional supports or alternative strategies may be needed. So this is also really helpful for you as you are moving towards meeting those goals. As you've been working with the client for a few months, you can go see if any progress has been made in the interventions that you have been doing. Have they been working? Have they not? And then the readiness for change. These responses give us an insight into the motivation, and it helps us tailor interventions using motivational interview techniques. So a strong progress note doesn't stop at what the case manager did. It also captures how the client is receiving this information. It helps us ensure our documentation reflects partnership, support, clinical decision-making, and it strengthens the golden thread connecting assessment, goals, interventions, and the outcomes. Next slide. Okay, let's see. All right, next we have our next steps, our plan. Every note must have what's going to happen next. This includes what the case manager will do, what the client will do, specific timelines, the next point of contact. Without the next steps, the documentation suggests that there's a standstill on the care. What is happening? So every note, you should have what the case manager will do next. This shows where your ongoing role demonstrates active care coordination. So a couple examples include follow-up calls, checking the status of referrals, coordinated with providers, and assisting with applications. What the client will do, you're documenting the client's part in the plan, reinforces shared responsibilities, and supports the client's growth towards self-management when appropriate. Dates and timelines are crucial. They show intentional follow-up and how auditors will see that the care plan is organized and there's a timeline in the interventions that you're doing and the work that you're doing. Appointments. This is also serves to include any upcoming medical, behavioral health, social services, school appointments, IEPs that relate to their care plan. This is where you will also use your notes as a way to reference back what is going on and what's coming up for your client. Any pending referrals. Here you're documenting referrals that are in progress and what steps still need to be made to close the loop on those referrals. Any updates to the care plan. This sometimes will be shifting. A goal is complete, new goals come up. Is there a new barrier that you're identifying? It should all be noted here just as to ensure that we are maintaining the golden thread concept. This section is really what is going to be tying everything together, and it shows a clear and accountable plan towards moving forward. So I just have a couple examples here for everyone. A case because these don't have to be full-on long documentation. Remember, we also have to make sure our notes are very straight to the point, concise, and not overly wordy. They can be as simple as a case manager will follow up with the housing intake on November 21st. And then you would add who the housing intake coordinator would be. You would add that extra information. Client will gather income documentations by November 21st. Next, the client will be scheduling appointment or follow up with you. This shows a coordinated task, shared responsibilities, and a concrete timeline of what the follow-ups would be. So these are very generic ones, but you would be expected to add into these any kind of specifics that are to your client's needs, which housing coordinator intake you're having them go to, what documents they might be needing. Any of those sorts would be something that you would be putting on there. This shows the coordinated tasks, the shared responsibilities, and the timeline. So it's just kind of going back and highlighting the next steps really it's your intentional planning, your collaborative care, the accountability, the continuation, the medical necessity. If a note ends without a clear step, it can appear like it's incomplete, it's disconnected from the care plan, so there is no tie back to it. Next slide. Okay, so the golden thread concept, as I've mentioned before in previous meetings, previous sessions, means that every note connects back to your care plan. Each note should clearly reflect which goals was worked on, what interventions was used, what progress and barriers occurred, whether the care plan needs to be updated. No goals connection will weaken your notes. This is a full life cycle of what a quality documentation would be. If your note does not reflect this sequence, it becomes fragmented and harder to defend. Strong notes clearly follow the clinical flow. Next slide. All right, so I want to touch briefly on the care plans section just to introduce everyone about care plans and what these would look like. So next slide. So why the care plan still matters within your progress notes. So progress notes cannot stand alone without a strong care plan. The care plan establishes the medical necessity, defines the success, and drives every documented intervention. Weak care plans automatically weaken all progress notes that are being followed. Next slide. So required care plan components. Here, I want to just talk a little bit about the required care plan components for an ECM care plan. Each care plan must have these elements to meet the DHCS. So when I say DHCS, that's our governing Medi-Cal standards. Supports clear care coordination and ensures audit readiness. These components help us create comprehensive person-centered plans that reflect the client's needs and priorities and strengths. So I'm going to break these down real quick. Client identifying information. So this is the basic demographic information, and it has to be very clearly identified who the plan belongs to. Who is your client? Who's the lead case manager? Important for continuation of care. Anyone reviewing the chart should know that when they look at the care plan, who is responsible and who is the keeper of this care plan and guiding the plan for that specific client. Initiation and review dates. These show how when the care plan was started, when it was last updated, regular review is required, especially when there are changes to the client's circumstances and needs. You are documenting dates of any updates that happen and review dates that you should be looking at. Client and family input. Remember, part of ECM core services is we really want to really bring in that support network, that natural support system. In your care plan, you should be also documenting any care plans, anything that was developed with the client, with the parents, the schools, anyone that's involved in that care planning. You want to really get their input. If you're including family input, it is essential when you're working with children and youth. If you're working with adults, do they have a caregiver, any other natural support systems that you want to include? You want to clearly document who those individuals are in your care plan. Strengths. We are really working towards having a strength-based approach as a foundation for the ECM work that we're doing. So documenting the strengths really helps us build the goals and the interventions that feel achievable and empowering for our clients. The needs should reflect what we identified through the assessment: clinical, social, behavioral health, systematic needs that the ECM work that you're doing is going to help to address. Risks and barriers. This includes safety concerns, SDOH barriers, service gaps, system navigation challenges. This informs the interventions that we're going to be using as case managers to really support the work that we're doing and that we're going to be documenting in our progress notes. Service recommendations. What services, supports, or referrals are you recommending based on the comprehensive assessment that you have completed and the needs that you have identified? Your skills as case managers is what are you recommending to your client to really help address that? And you are documenting it in your care plan. Client stated goals and preferences. So these are their goals, these are their care plans. So they should be written in the client's own words whenever possible. Preferences may include language needs, appointment preferences, cultural considerations, and how you want to engage in services. We really want to make sure that we are documenting anything that is important to them and we are really following their plans. SDOH diagnosis, this is a required under ECM services. We want to make sure our care plans kind of align with that. This shows the assessed social drivers of needs that justify why ECM services are needed and eligibility. Acuity level really determines the case management intensity and inform the frequency of contact. So each organization might have a different system of how they address and how they manage the acuity level, but in your documentation and in your care plan, you should have documented the recommended frequency of contact. How often are you going to be meeting with your client? What kind of contact are you planning to do with your client? Is it going to be in person? Is it going to be over the phone? Is it going to be like, what is their preference point of contact based on the needs and the preferences that they want, as well as their acuity level? How dire is it for you to meet with them on a weekly basis? How dire is it for you to meet on a bi-weekly basis? This is really important because you want to document, and it also helps have a clear understanding for both you and your client how often they will be having contact with you. So these are components to ensure that our care plan can be comprehensive, client-centered, aligned with your ECM medical necessity, and used across teams. This is what you can share with other organizations that you're working with as well, instead of providing everything, all your notes and so forth to other providers. Your care plan can really help kind of guide the collaboratives you're doing with other organizations. And it will also really help ensure that you are not duplicating services with someone else, doing the same exact goals with someone else. All right, next slide. Okay, so your progress notes should visibly track changes in strengths, movement on needs, and shifts and barriers. If these three areas never change in your documentation, your record will really not be supporting the work that you're doing. So we really want to make sure that you are tracking the strengths and your progress. Next slide. Okay, as we touched in the previous sessions on each of the goals, they must include a clear statement as well, a SMART goal, a specific intervention, assigned tasks, due dates, and notes. So this is your proper goals and interventions. Previous session, we went in a lot of detail about how to create those. But we want to make sure that when we are writing these into our care plans, that we are really clear and intentional on how we're creating these for our documentation purposes. Okay, next slide. Okay, when care plans must be updated. So this is also a very crucial part of the work that we're doing in our progress notes. So our care plans, you need to consider them as a live document. We are constantly updating these. They must be updated when goals are achieved, are changed, there's a new barrier that comes about, there's any acuity changes and shifts, contact frequency changes, or when we're having a discharge planning, when our discharge plans became, or disenrollment. Outdated care plans do not validate a strong progress note, so we want to make sure that we are following these guides. All right, next slide. So disenrollment and discharge section. So here I do want to touch every care plan, every service that we do with ECM services really does need to also have in line what your plan for disenrollment. So next slide, please. So here I really want to emphasize on the disenrollment of ECM. It is not just an administrative task that we are trying to complete. It should be a clinical process. How we transition our clients out of ECMs should reflect the same level of intention, care, and planning as their enrollment and active participation with the case management services. So we have to have a planned transition. This enrollment should be planned and it should not be abrupt. It needs to be thoughtful, client-centered, and coordinated with all the relevant providers and support systems. Whether a client is meeting their needs, they're moving out of the area, or transitioning to a different level of care, lower level of care, or higher level of care, we must demonstrate that the transition is going to be safe, appropriate, and well coordinated. Not just a case closure. This enrollment is not simply checking a box that services are ending. It is not a quick closure note. It is a clinical summary that includes the reason, the progress, and the next steps. It is especially important for audit reasons, and it ensures that the continuation of care will continue after your services have ended with ECM. So in your documentation, your disenrollment, you need to document why services are ending. Is a client meeting their goals? Are they no longer eligible? They're declining services consistently. They're moving to a higher level of care, lower level of care. We want to make sure that we are documenting the rationale for the closure. We also want to document the what. A clinical summary of what's improved, what's stabilized, what still remains. This captures the outcomes of your ECM support. The where care continues, who's taking over? Are you handing it over to primary care? Are you handing it over to behavioral health services? Are you transferring to a community health agency? Clients should never be left without a clear point of contact of where they can continue accessing services if they need it, or where to access the supports that they need. And then the how, the continuity is protected. This includes the warm handoffs, the transfer summaries, the scheduling the follow-up appointments, the giving your client the written next steps, really ensuring that they understand what that transition looks like for them. Your disenrollment should really tell the end of the story just as clearly as your care plan and your progress notes do during the middle of the work that you're doing with them. We need to really be treating the disenrollment as a clinical process. We reinforce quality, client-centered care, and ensure accountability with a seamless transition for them. Next slide. So just wanted to point a couple reasons for disenrollment. There are a lot more, but I really wanted to touch that clients may be disenrolled due to achieving their goals. They're stabilized, they're relocating, they're stepping down care. This is one that comes up often. They lose their eligibility, they lose their Medi-Cal benefits. The client doesn't want the service anymore, or you can't contact them during your outreaches. You're just not able to reach them. Each of these reasons requires a different type of documentation that you should be doing in your disenrollment. Next slide. So to complete a discharge summary, you must include the reason for the disenrollment, a summary of all the goals, interventions provided, outcome achieved, remaining risk referrals, warm handoffs, your client's participation, your last contact, next provider who is supporting, and then your anticipated discharge date. Here, required recommended elements are for your discharge summary. This is the summary that you will really be reviewing with your client and ensuring that they understand where to go to and what the plan is for them. It should clearly tell the story of why ECM services will be ending. Okay, next slide. Your discharge documentation must clearly reflect the golden thread. So your assessment, your goals, interventions, outcomes, and your transition plan. This shows that what changed, what worked, what remained the same, and now who holds that responsibility. So just re-emphasizing that. So loss of contact cases are a major compliance risk. So a lot of you sometimes will have clients that they're just not answering that phone anymore. You're attempting outreaches. You must clearly document all your outreach attempts, your methods that you use, the timeframes, your engagement barriers, any safety considerations, closure decisions, referrals provided. If you are not documenting your outreach attempts, this really equals an audit vulnerability. So the alliance, your payer source will be looking at what attempts were made for your client to reach them. Next slide. And do also want to touch on the disenrollment versus abandonment. So this is an ethical consideration that we all hold as case managers and as clinicians doing the work that we're doing. Ethical disenrollment is really advance notice, referrals, education, and the warm handoffs. Abrupt closures without the continuation of care planning may be considered abandonment and creates a clinical and legal risk. So when we are working with our clients, we really got to ensure that we are doing our diligence and really supporting the work that we're doing. Next slide. Okay, and then final progress note should show your discharge readiness, reduce the case management intensity, increase self-management, follow through on referrals and the maintenance of goals. Discharge should never appear that it is sudden. It is a planned process from when you first started services to when you're ending your services with them. Next slide. And then common pitfalls. Most frequent problems seen in audits include vague notes, missing goals, judgmental language, documenting tasks instead of interventions. You're not documenting your client's voice. You're missing follow-up plans. And I want to emphasize the copy and paste of your documentation without updates. I know a lot of us are really trying to document and get things done, and checklists, I'm for them. They're the best thing ever, but please proofread your notes. If you're doing a cut and paste, make sure you are very diligent and aware of what is going into your notes, because if it's the same note appearing over and over and over again with the same language and there is no updates, that is not passing your audits. So careful with the copy and paste. Next slide.
Thank you, Esmeralda.
That was a lot of
I know.
information.
Yes, it was. It was a lot of information. What I appreciate is that HIP is able to share all of these, the slide deck specifically with all of you, as well as all of our attachments such as tools to support this work. Very heavy lift to kind of try to get this all done within the time frame that was allotted. So I just want to go over the key takeaways. Care plans. We want to make sure we're justifying the services and that we are all working hard. That's obvious as case managers, as ECM. Doing this work is intensive, and so we want to make sure that that work is being reflected in our note. Okay. And one of the things that we're going to emphasize and we're hearing a lot from, Central Coast Alliance for Health and some of our others managed care programs is the value and understanding around discharge summaries and making sure that we're proving impact. So always making sure that that's there. Again, we want to also have the client voice, skills-based community case management interventions, our medical necessity, continuity of care, and compliance with the programs that we're supporting. Next slide, please. Next slide, please. Awesome. This work matters, and the work that we're doing is so valuable, and we want to make sure that we're supporting with the alignment of again CalAIM of our managed care programs, and that our documentation is strong. It's protecting you, it's protecting our clients, and it's protecting our agencies to support what we're doing. Again, reflecting impact and strengthening our system of care. So thank you all for the work that you all do and for your commitment to quality, ethical documentation, and for supporting us through this process. Any questions? We do have a few minutes this time.
I just had a question. I wanted to know if these video slides would be also sent to us just as a kindly reminder, because we're always so busy with our participants and stuff, so we can reflect on back on this whole video slides.
Absolutely. And I don't know, but Anissa, if you want to add to that, but yes, they will be included.
Awesome, thank you.
Yes, we will have a follow-up email with all of the slides and materials. So thank you.
I have a question. For the discharge summary, is that an additional documentation or a document that we need, or can that be a summary within an HMIS note?
So each organization has discretion around how clinically they would like to have a discharge summary created. So what we wanted to highlight is key points for discharge summaries. And in the work you're doing with case management, the Alliance in general, and Berenice, you can correct me if I'm wrong, does not ask specifically for a discharge summary. They do ask for the PCR when you're disenrolling someone. They do ask for similar information. It's just not formatted in this specific order of how they're doing it.
And just to kind of close that question, I think that as an agency, you all can go back and say, do we want to have a universal document to utilize, or is it something that's just going to be reflected, not just, but if it's going to be reflected in our actual note? So again, we have tools, and some of the tools that will be sent out with this presentation is what it could look like. Not the full tool, but something that can really support your agencies.
Amazing, thank you.
No problem. Great questions. I'm trying to see if there's something I missed. No. All right. Do we have a poll to go out, Berenice?
Yes, we do. So I'll
Great.
queue up my team so they can get that up for everyone to complete. And just again, thank you so much, Darlene and Esmeralda, for walking us through clear, skill-based, and trauma-informed documentation for progress notes. Again, for everyone on the line, before you all hop off, we would love if you could complete our post-training survey. This helps us capture any shifts in learning and any key takeaways you're taking from this session, or remaining questions or areas for future learning as we look into planning more sessions for 2026. And so